Hey everybody, this is Chris of the Ancient Scholar, and this is going to be the third video in a series of videos where I discuss corticosteroids, and in the pre-hospital / emergency setting. That's going to be the focus, or has been the focus of these videos. So in this video, I'm going to be talking about specific examples of corticosteroids, and I have a really nice little reference here. This is actually a comparison chart that the National Adrenal Diseases Foundation, or the NADF, put out. And I think it really helps highlight and helps us understand the different types of activity that we see with a variety of corticosteroid agents that might be used in a therapeutic setting in the emergency or intensive care setting. And like I said, you can really narrow your choice of corticosteroid down to the activity that you want. So are you wanting mineral corticoid activity? And remember that mineral corticoid activity is mainly going to be the sodium retention and the subsequent water retention. Or are you giving a corticosteroid because you want glucocorticoid activity? And that is primarily going to be the anti-inflammatory effects that we're looking at. Or are you wanting to give an agent that is providing a balance of glucocorticoid and mineral corticoid activity? So that's really what it comes down to when it comes to a choice of agent. And then, of course, these agents can have a variety of durations of action. And up at the top here, you have your short-acting corticosteroids, your intermediate-acting, and then your long-acting. And these middle columns, I think, are the most important for us. The anti-inflammatory effects in this column here are primarily glucocorticoid activity, and then mineral corticoid is, again, primarily the mineral corticoid or the sodium retention and water retention activity. And these are all going to be relative to hydrocortisone. And if you recall from prior videos, cortisol or cortisone gets converted to hydrocortisone. So under the short-acting category, you have these steroids, these corticosteroids, that are going to be very similar to the cortisone that the adrenal cortex releases, and they're going to have very similar effects. So here you see the hydrocortisone is going to have an anti-inflammatory activity of 1 and a mineral corticoid activity of 1, or glucose/mineral corticoid of 1:1, because this chart is comparing everything to hydrocortisone. And if you recall, cortisone gets converted to hydrocortisone. So if you administer something like cortisone acetate, its effects are going to be roughly on par, very similar to hydrocortisone, because cortisone acetate is essentially a prodrug, and that is going to get converted to hydrocortisone, and you're going to see a fairly similar duration of action. The plasma half-life is not, I don't think, as helpful, so I'm going to just kind of put a line through that, because a lot of that is just how long does that medication remain in the blood plasma. So how lipophilic is it, and how quickly is it going to pass into the intracellular environment? And it's really the overall duration of action that I think is most important from a clinical standpoint. And so you can see these short-acting corticosteroids are going to have a duration of action of around 8 to 12 hours, which is the shortest kind of duration of action that you're going to get. And then you move on into your intermediate-acting agents like prednisone, prednisolone, triamcinolone, and methylprednisolone, also known as solumedrol. And this is a very commonly administered agent in the pre-hospital context or the emergency context, Solumedrol. So I'll give that special mention. And if you recall from prior videos, I believe I mentioned the relationship between prednisone and prednisolone, and that is to say that prednisone is a prodrug, essentially, of prednisolone, and if you give prednisone, it gets converted to prednisolone. So when you look at their potency, their gluco and mineral corticoid potency, they are going to be roughly on par. And you'll notice that these intermediate acting corticosteroids have far greater glucocorticoid effects than mineral corticoid effects. All right. And so the mineral corticoid effects are going to be fairly similar to hydrocortisone, if not less in some cases. For example, triamcinolone has no mineral corticoid activity, and methylprednisolone has about half of the mineral corticoid activity that you would see with hydrocortisone. And this actually helps explain why we might want to administer something like Solumedrol in the pre-hospital environment, because we're going to be giving this primarily to treat inflammatory conditions in the respiratory tract, asthma exacerbations, COPD exacerbations, reactive airway disease, as an adjunct to treat anaphylaxis and severe anaphylactic reactions after you've stabilized the patient. And you're not really giving the Solumedrol for its mineral corticoid effects. However, let's say that I am taking care of a patient that is having or experiencing Addison's crisis, where many, if not most, of the immediate life-threatening manifestations of an Addison's crisis are going to be mainly due to the mineral corticoid effects. That is to say that somebody does not have enough cortisol, and they are not able to retain water, they're not retaining sodium, they're having problems with potassium, they're getting hypovolemic, they're hypotensive, they're not perfusing, and of course, you do get some glucocorticoid, a lack of glucocorticoid effects, mainly in that they can have difficulty maintaining adequate blood sugar, and they can get hypoglycemic. And so if you're treating someone with an acute Addison's crisis, a medication like Solumedrol is not going to be as helpful, because it only provides about half of the mineral corticoid activity that we see with something like hydrocortisone or Solucortef. And this is why in the setting of an Addison's crisis, something like hydrocortisone is going to be preferred over something like methylprednisolone. However, if we're giving this to someone with asthma, or maybe this is a child with upper respiratory inflammatory pathology, prednisone, prednisolone, or methylprednisolone may be better options, because they have more potent anti-inflammatory or glucocorticoid effects. And we see that in the long-acting agents. The long-acting agents have even more glucocorticoid activity and little to no mineral corticoid activity. And then you move down to this last row of medications, and these are medications that have a profound amount of mineral corticoid activity compared to the glucocorticoid activity. So these include things like fludrocortisone, which has it's actually very potent glucocorticoid effects, right? 15 times what you would see with hydrocortisone, and incredibly potent mineral corticoid effects, about 150 times the activity. And of course, it is fairly long-acting. It is kind of in the intermediate to long-acting range. And then we can just compare that to the hormone aldosterone, which has no glucocorticoid effects, and we know that aldosterone primarily impacts the renal tubules, and it has about 400 times or more the mineralocorticoid activity. So it has pure mineralocorticoid activity and no glucocorticoid activity. And so administering aldosterone to somebody with an inflammatory condition is not going to be particularly helpful because you have no glucocorticoid activity. So hopefully that makes sense why there are certain medications that we administer in certain situations when thinking about the administration of corticosteroids. It really does come down to the activity that I want. Do I want something with glucocorticoid effects, mineralocorticoid effects, a combination thereof? And what duration of action am I looking at? And that really should help you all better understand and conceptualize why certain agents are prescribed and administered for certain situations. All right, everyone. Hopefully you found this video helpful, and we'll see you in the next one.